I'll look up. So good afternoon at this time, everyone. Dr. Letha Maybank, and it's a pleasure to be here to talk about the center and the work that we're doing. I'm excited to hear the work that you're doing, and I heard about it before, but also just read through a little bit of the bulletin as well. We're at an interesting time and a very good time in the city in the sense of equity being a lens for many things that we are being charged to do, as well as equity really being pushed to the forefront of conversation. And what do we mean by that? And I believe as a city, we naturally should be in that space, and we're such a diverse city and we should be moving in that direction, but I do feel that because we're New York City, we are extremely diverse. We tend to, even ourselves as public health people, researchers, whomever, practitioners, clinicians, we tend to encompass a lot of assumptions as well about what it is that we know and understand about addressing equity as the lens. And so throughout this, this to me is more so becoming a story the more that I do this work of how do we really challenge ourselves and how do we really challenge our institutions to better understand what do we mean when we say the word health equity or equity in general. What are the processes that we need to put in place? How do we have to change our practices? And how do we ultimately achieve progress? I actually just came from a meeting with the commissioner, and we're talking about our internal organizational change work, which I'll get to in a second. But she talks about process and important, outcomes are important, but progress is just as important. And a lot of the equity work, especially around health, we've done a lot of process over the years. But when do we get to the point where we're actually starting to decrease the gaps? I say the only reason why the center is here is because we have this disparate outcomes that happen in our neighborhoods. If they weren't here, if they weren't there, we wouldn't be here. And so for my staff, it's always keeping an eye on that particular prize of how are we closing the gap? What are we doing to do that? And to always be evaluating our processes. And so in New York City, we know, and hopefully most of you know and hopefully believe, that the mission of the New York City Department of Health is to protect and promote the health of all New Yorkers. And we are a city of many, many, many neighborhoods, and many neighborhoods that have lots of history that have occurred in those neighborhoods that influence what is happening currently around health, what's happening around income, what's happening around economics and education. Our role is to ensure, though, that all New Yorkers, when it comes to health, have the same opportunities. And that's usually the definition that I use for health equity, is it's to ensure that all New Yorkers have equal opportunities to achieve optimal health or achieve their full life potential, full life health potential. But we're clear, many of us know that there are health outcomes that are different based upon what neighborhood you're located. And I'm sure many of you have seen these maps. They're very familiar and popular in our line of work in public health. But really looking at most of the disease outcomes, this is hospitalizations as well and infant deaths. And when we look across the city, we're very clear that there are neighborhoods that consistently have worse health outcomes than other neighborhoods in the city. And you can see it from here, North and Central Brooklyn, which is usually around Bed-Stuy, East New York, as well as Brownsville. And then you have South Bronx, as well as East and Central Harlem. And then we also know that there are areas in northern Staten Island also that the health outcomes tend not to be as great, and then Jamaica and Corona area of Queens. So there are definite differences in neighborhoods across the city. And we feel, and we believe, and it's our value statement, that this is not fair, that it's unjust, and we have a role to play, a key role to play in making sure we highlight that and bring that attention awareness, but we also change what we're doing within the health department, and then think through, it was mentioned before about partnerships, how do we work with other city agencies to also help them evolve their work so that we are addressing these exact differences in neighborhoods. We know life expectancy is also different. It follows the same pattern. We can see, and this differential actually is between this is about 10 years, and we know that folks in Brownsville, their life expectancy is 11 years less than it is in the Upper East Side. And that's tremendous, and it should really be appalling and shocking to us. Violence, the same conversation, the same pictures. Violence, we see many neighborhood differences in the same neighborhoods that I mentioned before. And then underlying and really where we are really pushing our conversation here in health and that health equity in New York City is the conversation that we have not only about class and poverty, but its link and its connection to race and racism. And that racism is really a tremendous structural barrier to segregation or causing segregation or leading to segregation of neighborhoods that creates these health outcomes that I have showed you earlier in the previous slides. And that a part of our role as the health department is to explicitly say that and to state that. There are health departments that do it across the city, or the country rather already, or that are really at the forefront of saying racism is a structural barrier and that we need to figure out how we address it. And there are others that don't. And we feel in New York City we've kind of hidden a little bit under it for a little while. And the role and the goal of Commissioner Bassett is to make sure that we are talking about it explicitly as a barrier, because it does influence how policies are created, those who are creating the policies, and the solutions that we know are important, or at least the process to create those solutions that we know are important in order to address these health inequities and eventually close the gap. It is a very important part of the conversation of how we deconstruct race and racism. We know that there are policies over time that have created these systems of unbalanced power and privilege. And as I've mentioned before, they have existed over the life course, and they are very historical. And they have led to geographic concentration of poverty. These are very, I believe, very important concepts to understand. Anybody who's doing research in neighborhoods in New York City is that you're not only working on your isolated neighborhood, you are working in a neighborhood that is created based on the circumstances usually of other neighborhoods or the history of other neighborhoods that in the city and what has happened historically as in regards to policy, as well as large institutions and their relationships with the neighborhoods that they rest in. And so what have we learned in the field of health equity? I recently went to a presentation in Tampa, and it was really more of a convening of all the health departments who have Centers for Health Equity on the East Coast. And we talked about the field of equity, and we're the newest one in the country, actually. And that many people feel that equity really started, and I'll go through a little bit where it started, but really started within the recent years. And the reality is, and this to me is another power, privilege, racism conversation, this conversation started a long time ago. It's whether or not who was paying attention to it and who was putting the money to it. And so it's important for us to know that, and W.E.B. Du Bois is really the first person who documented in the Philadelphia Negro in 1899, or 1906 rather, the Philadelphia Negro in 1899, and then did the Health and Physique of the Negro American in 1906, documented the life of and the health of blacks, and really it was ex-slaves compared to whites in Philadelphia. And it's a wonderful, it's really the first sociological document. It's about this thick. It's very intense. He was the first black man to also get a PhD from Harvard. But it's an excellent, excellent book and an excellent demonstration of how you do a complete holistic assessment and analysis of all the different factors that we know, that we hear the jargon language of social determinants of health, but all of these factors that create health. And he did a great job at outlining every single one of them, the conditions of the neighborhood, what jobs people had. And the language back then was also much less politically correct. So people said what they wanted to say and how they wanted to say it. But I recommend anybody who wants to really see some good research or interesting research done many years ago, looking at disparities and highlighting some of the social inequities primarily, to really go to this document. But he was really the first person who highlighted this for us. And so it continued to evolve. We know in 1985, and this is really when it came to the federal forefront, for the Department of Health and Human Services, Margaret Heckler, who was the secretary or the assistant secretary at that time, issued a report that identified that in that particular report that 60,000 people needlessly died due to the lack of access and quality health care, and predominantly African Americans. And this really generated lots of attention and movement and policy shift in the country. And this was the start of the offices of minority health, of which some are still called, but that language has evolved as well. But the offices of minority health started at that time in 1986. And there are several states across the country. I think there's about 32 or so states who have offices of minority health. And then there are also local level of offices of minority health. But many of them have shifted their language to either using social justice or centers for health equity as well. Then in 2010, we know the U.S. Department of Health and Human Service launched Healthy 2010, and that was the first time they had two goals, and the one goal was eliminating health disparities, and then 2002 really propelled the conversation, and this is the time when I finished school, when I was in my residency, and this book came out. And it was the Institute of Medicine's Unequal Treatment Confronting Racial and Ethnic Disparities in Health. And this is what really, I think, propelled the conversation and action as far as it goes. So we had the policy level on the federal level, created the Office of Minority Health, but now we have a shift into, this was showing and highlighting the discrimination and racism that was occurring within the medical profession. So it was saying that they had tons of studies that they pulled together stating that even though they had African Americans and whites and people of different racial and ethnic backgrounds that had the same economic status, the same education status, they were getting unequal treatment. And there were plenty of studies to now document this, so much so that they were able to do a complete book. And this is the federal government that actually pulled this together. And this was the time then you started to see in medical education, you started to see language about cultural competency pop up. And now schools are starting to talk about health disparities more so at that time, not so much inequities, but disparities. But what we've learned between 1960 and 2002 is that even though we know that we have improved health overall, and especially here in New York City, this is a pretty healthy city. And we have decreased the inequities that exist. It is possible. But the reality is that they still exist, and we know in situations where the gaps are actually getting wider because we're not having enough focus and direct focus on these gaps. But the gaps are actually getting wider because health is not improving equally across the city. And so we're at a crossroads. We can look at different social legislation of the 1960s. So and I'm going to talk a little bit more about this, a lot of our work and what I'm seeing on the front line of health equity is not only talking, so we have policy, we have data, but now it's shifting to how do we support, and this is what the talk is about, the capacity to act. How do we help strengthen communities to act on changing what is happening in their neighborhood? The reality is many communities, and I hear this a lot, that people don't know what's going on with them, and they need to be told this and they need to be told that. People are very clear what their environments are like for the most part, and are clear what they have and what they don't have. And oftentimes when we talk about conversations of power and privilege, it's how do we build power into communities and with communities so that they know that they can overcome or that they can achieve or they can go somewhere or they can be powerful with somebody else or some institution so that they can create change themselves. That is really the bottom line of a movement. And we're at a time where there's a lot of movement that is happening across the country. There's a lot of conversation. We see it with Black Lives Matter and everything that's happening in the media lately. There's a lot of I would say, agitation in a sense that we need to start doing things differently. And there are people who are ready to do it and young people who are ready to do it as well. And I think that's the forefront and what we're learning from the public health field and those who are doing health equity at the front line is how do we get the agitators to help join into the conversation of health and really start to organize around health inequity. And you're going to, and people are kind of shocked to hear a doctor and a government person talk organizing language. The commissioner does it, and she's very much an activist, but this is kind of her leadership, and I think where we're understanding where, when it comes to power, how we have to help work and build it in our communities and with our communities. And so inequities exist because groups benefit and hold power as compared to other groups. There's a power over. And so we believe that one of the solutions is how do we have an inside-outside strategy? So our inside strategy, mainly building our organizational capacity, I'll talk about that, what we mean and some of the work we're doing around that. Our power of partnerships, which I heard earlier. And partnerships not for the sake of just having a partner, but finding out who your true allies are, and then having allies that also have a base of other people that you can work with and engage other folks into the conversation and solutions around health equity. So it's not just simply I'm collaborating to just, we say collaborate, because I see that happen a lot. I've been doing this long enough and I see the language. I think we have to become more concrete when we're working with people. What do we mean? How are we coordinating? What are the steps we're going to take to coordinate to make sure you actually have action that's happening together and outcomes that are going to flow with those actions? And then how do we elevate voices in planning? And so part of a lot of what we have to do is change the narrative of what determines good and bad health. There was a recent poll that came out this year that if you ask the majority of Americans and you ask them what creates good and bad health, most people will say their health behaviors. And if we walk down the street, most people will say that. And so we have to learn at public health, one, to how to use communication tools a little bit better and strategies that I believe that commercial marketers learn how to use very well, and they hire marketing people who can actually do this and help change the narrative around what health is, and that health and behaviors are really influenced by the environments in which people live, which are then influenced by the policies that have shaped those environments, which are then influenced by the people who create those policies, which are usually influenced by cultural and structural norms that are in a context of power and privilege. So all of that shapes our health. But we have to figure out how do we communicate that to most people who are not in public health in a way that engages them into our conversation. Or we kind of meet people where they're at more so than we expecting people to meet us where we're at. So it's a power with. We have to build the internal capacity of our agencies, and so the health department. So a large part of our work, we're the largest health department in apparently the world, the urban world, with 6,000 employees. We have to figure out, part of our internal capacity building is how do we get people on board with understanding what health equity means? How do they change their policies? How do they change their practices and what they're doing? How do they understand that who they recruit, where they recruit from, impacts who they bring into the agency, therefore impacts who delivers public health, and how we develop our partnerships also becomes very important. So there's a lot of training that we have to do. There's a lot of assessment we have to do of our employees and a lot of training. And there are several great models in this country. Boston Public Health Department, the commissioner there, actually has every single staff person participate in 22 hours of undoing racism training, every single employee. And so it's that type of leadership, it's that type of commitment on not only, clearly it's not just the commitment to say it has to happen, it's the commitment of staff time to make it happen, and then it's the commitment for allowing your staff to have it happen. So it's time and dollars, but they felt it was a very important process, and they're really sought after as leaders in doing this kind of work. Other strategies, building, fighting, and elevating demand, which I'm going to give some examples a little bit later. But again, we have some great organizations across the country who are doing this. They're working with organizations doing some base building. They're usually run by community organizers. They have experience bringing and mobilizing people around a common goal. That's why community organizers are pretty valuable in any kind of work that you do, even if it's research as well. And they typically work to address the social determinants of health. An example of this is in Minnesota. Their strategy, they had an inside-outside strategy, but their strategy was really working with community organizers who focused on income and wage, as an example, increasing the minimum wage. And what they were able to do, because health, for the most part, all of us are connected to health. Everybody's connected to health in some way or shape or form. Whether it's their own health, their family's health, health is definitely of value for people. Whether or not they create action around it and do something about it is a whole nother conversation. But what we're clear is that it is able to pull people to the table. So if we can put a health lens to something such as minimum wage or incarceration or housing, we can potentially engage a whole group of other people in the conversation around health equity that weren't necessarily at the table anymore. And then you have the potential to actually start and create and to build a movement to help create changes and think about solutions in a different way. that are addressing these root causes of health. Because everybody says, well, we need to address the social determinants of health, but most of us are very challenged in how do we do that? What do we do? I hear we struggle. And so it's one of those, this is one of the ways that people are moving in the front line of health equity. So for the health department, we have some strategies that we're implementing as far as how we are addressing equity. And one of them is improving our neighborhood health strategy. Some people may have heard of already of the district public health offices. These were started in, almost 10 years ago, when Dr. Bassett was first on board. And this was a way to, it was clear that those maps that you saw earlier, these inequities exist across the city, these disparities in health. How can we address it? How can we have some local context to what's going on? How can we develop relationships, understand, look at research, and deliver services that were on a local level? And so she started and opened the district public health offices in these 3 communities over 10 years ago, and they still exist to this day. And the goals over the time, and what has happened really, is lots of relationship building. We have a relationship with faith-based organizations, schools, other city agencies, community boards, parent groups, you name it, we have the relationships, which is a really helpful process because I'm sure, as many of you know, everything we do is all about the relationships that we have. And trust is an important part of that. And so building trust over time has been extremely valuable in the work that we're able to do out of the district public health offices and as the health department as a whole, because we are able to call upon people when we need them, and they're able to call upon us. We have research units in each of these district public health offices that do community level research and working to understand the environment. So a lot of the work we understand about the food environment, bodegas and retail really came out of the district public health offices initially in the city. And then there's also programs that delivered out of each office. The Bronx has a teen pregnancy prevention focus, Harlem has an asthma focus, and Brooklyn has a maternal child health focus. But honestly, all of them could have the same focus because all neighborhoods pretty much have the same and similar issues. And they all do work around obesity and food and fitness. They all do work in those areas. And so when the commissioner came on board about a year ago and really wanted to have this explicit focus, one of the first initiatives that were started that the mayor actually really agreed with because of his work that he's done overseas was to start a community health worker initiative. And so this is a very neighborhood-based, place-based initiative that is focused on 5 NYCHA developments. And that's what makes it unique, is that it's actually focusing on the developments itself and working with the development, the tenants and residents within the developments. And so the Community Health Worker Initiative, there's 15 community health workers for the 5 developments, and some folks are coming from the developments themselves who are the community health workers, which is how it should be. But their goal is to coach residents and to have healthy behavior change. So in the first year, we're supposed to have 400 residents that are coached on diabetes, whatever they need the coaching on, but it's on diabetes, hypertension, and asthma are the 3 initiatives or 3 diseases that we're focusing on the first year. And then the second year, we're going to expand it to 800 more residents. The other piece is how do we also work with the healthcare systems? And so we're within the particular neighborhood, understanding that even all the work that we do with the patients or the community resident within their environment, when it comes to clinical outcomes, it's very important that we have to connect, we as a health department have to connect with the clinical side of it. And so we are engaging with clinical stakeholders. Actually, we were able to find kind of who are the top clinicians that folks are going to within this neighborhood. And so we are convening the clinical stakeholders and getting their ideas and their sense of, what is it where their gaps are, where their assets are, and how can we better coordinate so the residents there are able to get services better in the way that's working for them. And then we're also going to be working with the payers and the providers. The insurers such as Health First and several others are very interested at sitting down at the table and thinking through how whatever role they feel that they can play, which I'm sure is a great one, they're interested in sitting down at the table and starting to partner as well. So we're starting to plan in that way. And then the last piece of kind of what I mentioned earlier is how are we building the capacity of the residents themselves in order to create change for their environments. We know There are many, I don't like to say the word issues, but there's a lot that's happening for families that are living in NYCHA developments. A lot that's happening in their own personal lives, whether it's with their health or with their jobs or with their families, a lot that's happening in the housing itself, and a lot that's happening in the neighborhood as it relates to violence. And so as I heard Reverend Emma Simpson, who used to be at the Children's Defense Fund, say recently, being poor is hard work. And it's really clear, you know, when you talk to the community health workers and some of the stories and the experiences of the lives of people living there, tremendous. And it's challenging on every single level. And they have to have so many more questions, conversations, processes, just to get out of their door many times as compared to how we do when we have more privilege and we have more power. And all of this impacts health. And so we're realizing, as many people have a sense of, is that it's not just about the physical health condition, but it's all the social health conditions and all the social determinants of health that really impact somebody's day-to-day experience. But how can we as systems help affect and change those day-to-day experiences is what we're working towards as well. And we see this as an opportunity to be able to highlight the experiences and the challenges as far as on a system basis, and then be able to connect with other city agencies. Another strategy we have is meaningful community engagement and utilizing collective impact as an approach. Some of you may have heard of this. It's basically in which you are now working with, and this is really a model that's been in place, but it's another kind of jargon term in a sense now at this time. A lot of people are using it. But basically you have your backbone organizations, your key organizations that are partnering, they're coming together, identifying their assets, working on a place-based effort. They create shared agendas, a common agenda that all people can work towards. They have shared measurements and goals, and then they have ways to communicate, and they have mutually reinforcing activities. And that approach is how we're starting to really engage with our neighborhoods. So I said before that we had lots of relationships. We do have lots of relationships. And there are many times in which, you know, we're able to kind of give information, do some level of consulting, but getting to the point of shared leadership as far as a meaningful way of community engagement, we're constantly trying to push ourselves towards now at this point. That is an approach to advance health equity. How do you get to shared leadership, where it's beyond just delivering information simply and asking for information back, which we call consulting, but you're actually getting to where folks are all sitting at the table together to do planning together for that particular neighborhood or whatever the project and plan is, so that those who are experiencing the greatest health inequities are also at the planning table, and they're not just being asked about, you know, their reflections on something after the point. So one of our processes, and this is a new initiative that is launched by the Health Commissioner, called our Neighborhood Health Hubs. And this picture is the East Harlem building on 116th Street. And this plaque is what triggered it for the commissioner. And it basically says, I can't read the print so well, but it basically says, in commemoration of all there were like 22 city agencies there at the time, in commemoration of the East Harlem Health Center, as well as the New York chapter of the Red Cross. They're basically put this plaque on the building, built this building to say that these 22 agencies were going to come together to do planning over time. And this was really the beginning of the health center movement. This happened this building was erected in 1936, but in 1920, American Red Cross came to the health department post-World War I and said, you know what, during disastrous times, we figure out how we coordinate really well. We're really good at doing that. But once a disaster is over, we go back into our silos and operate the way we've always operated. And so Red Cross was saying, well, why don't we try to figure out how to coordinate in the same way we did during the wartime? They felt that the best way for this to happen was to bring health and welfare agencies, of what they called them at that time, bring them under the same roof so that they would be more likely to plan together. And plan together for the East Harlem neighbors specifically. So they chose East Harlem because at that time, this was a community of immigrants, of Italian immigrants, as well as Puerto Ricans who were just able to just get into the country, and this is where they were resting, was in East Harlem. And they noticed that the health outcomes were not the worst in the city, but they definitely were worse than other areas. And so they felt that if they focused their attention in East Harlem, maybe they could achieve some goals to improve the health of the residents that were in East Harlem. And so after a 3-year pilot, successful, they felt, they actually received funding from the city to build this building, and it was this building that triggered the building of 30 other buildings across the city. So all the district health buildings are because of this movement that started in the early 1920s. And this was the health center movement. Health center really was a space for planning, for coordination, and to help prevent duplication for that particular neighborhood that it was resting in. Health center over time has really become synonymous with clinical services. And so we're trying to re-envision this work and shift back to this joint planning in which organizations, not only us as a health department, community-based organizations, as well as city agencies are going to be in the same buildings across the city in order to do community health planning for their neighborhood, along with planning councils of the neighborhood as well. It's the same structure from over 100 years ago. Another way in which we have been working with and finding and elevating the demand that I mentioned earlier is through our bike lane work in Brooklyn. And this was an effort that actually started because we received funding in Brooklyn to encourage people to be more physically active and to eat well. And went to our residents and said, you know, if we wanted you to bike more, what needed to happen? They said it has to be safe. Brownsville Partnership, who's also in Brownsville, got the same funding. The state knew it, so we were able to kind of pool our resources together. We brought DOT to the table at that time. They were very open because they were receiving a lot of negative attention from communities like Park Slope and Bed-Stuy about just plopping bike lanes in people's neighborhoods, basically, and people not feeling that they were being respectful, and some people feeling that it was racist that they were there because they were slowing down cars and the fumes were getting into their lungs. And then some people feeling that bike lanes not in certain communities was being racist as well. So this was an opportunity for us to sit down with big power brokers in the city and our community residents. And it was our community boards that really guided this process the whole way through. And I have this because Brooklyn was actually the first place of the first bike path in the world, actually. And biking was always considered something of the elite, especially here in New York City. But we have known that, this work is not about just bike lanes, and we had to make sure, so this is, again, what is your internal strategy? What is your organizational change process that helps you get to this point so that you can actually sit with your residents, have residents at the planning table so that we can actually talk through these issues that are going to come up of what bike lanes really represent to people and what they may represent to people. And a lot of times, the exclusion, gentrification, displacement, and just misperceptions about people's willingness and wanting to bike. And a part of our strategy, and this is usually the strategy for when you engineer a community, but we added a 6th strategy, and that was meaningful community engagement. And so at the beginning of the process, this box here is what represents Brownsville and East New York. The lines are bike lanes that were already existing, and you can see there are not many in that box yet. And so at the beginning of it, DOT had proposed putting 7 miles of bike lanes down. By the end of the community planning process, which took about 2 years, and 2 years in which we did walkability assessments, we taught residents how to do that. We did community bike rides with residents to kind of understand infrastructure changes that needed to happen. From 7 miles, the community proposed 20 miles of bike lanes, and so DOT is actually placing 28 miles of bike lanes down in Brownsville. And this is because of the planning process that took place. The planning process in which all voices who potentially are affected or affecting the area were at the planning table. And so in this work, Dr. Bassett talks a lot about Black Lives Matter. She wrote a piece in New England Journal, if you aren't familiar with it, that came out last month, and really speaks to how do we create that level of change in communities? How do we create that level of transformation where you can actually see systems, the physical system, the physical environment in which somebody lives in actually changes, is hard work. But it's possible, and how do we get there? And she talks about how, again, we as systems, as institutions, really have to look internally. We really have to challenge our own selves. We have to challenge our lenses. We have to challenge our understanding. And honestly, she says, being very explicit about racism. And we have to see how that impacts all of the systems that we have currently. And how does it impact how we bring people to the table? How does it impact solutions that are made? And how does it impact policies that are created and implemented? But there are many opportunities, and that process that I explained earlier not only changed us as the health department, it clearly changed DOT and their understanding of how to engage with neighborhoods. I don't feel that beforehand they even believed that this was going to be as rewarding as it was going to be, and that they had the potential and how this could lead to action across the city. And so now is it not only in Brownsville, but they're taking this other neighborhoods and going through the same process of engagement and realizing it's a better process, and it's a process that makes sense for everybody, and it makes sense in where the lanes are placed. You know, you prevent duplication, you prevent having lanes on streets that don't make sense, because the neighborhood's going to tell you that, and they're going to provide their expertise. And it's understanding that we all have expertise. Community residents have expertise about the neighborhoods that they live in. And so my last slide is, cities have the capability of providing something for everybody only because and only when they are created by everybody. And this is at James. Most of us would think are familiar with Jane Jacobs, and this is a picture from Brownsville, at Brownsville's got bike lanes. But it's very important that if we are really interested in solving health equity and getting to the point of decreasing gaps, we have to engage those who are experiencing the disparity, the inequity. It's essential. That's how any movement is created in this country, whether it's the gay movement, the civil rights movement, the women's movement, the labor's movement, is started and sustained by those who are experiencing the injustice. And so if we as institutions do not recognize that, help facilitate that capacity to act, we aren't going to really decrease the gap. So I always push staff, push audiences to remember that and think about what are you going to do differently in order to help support that capacity to act. That's it. Thank you. Sure.
Good afternoon, Dr. Maybank. It's so good to see you again. I'm Barbara Hart, the Executive Director of the Bronx Health Link. We've had many discussions in the past. The Bronx is known for being 62 out of 62. We have more of everything from diabetes to amputations from diabetes, HIV/AIDS, to just, we're a mess. So one of the things we're doing is we're collaborating, with a number of organizations. CBOs have gotten together to see what we can do to change this. And when we looked at the whole map in terms of what the rankings were, we noticed that Brooklyn went from 50 to now 43. Since you were there, you were head of the DPHO in Brooklyn for a long time, for a while at least. Can you share, what did Brooklyn do that made them go from 50 to 43? Because we're stuck.
That's a good question. I actually hadn't seen, I know the Bronx statistics, but I didn't know Brooklyn jumped that high. I think there are many factors that contribute to the improvement of health in a neighborhood, or at least for the statistics to improve in that way. I think Brooklyn is a very changing borough, and there's lots of shifting of people in and out of Brooklyn, and really the word is gentrification. I think plays a role in it. I think the neighborhoods are looking differently. I think the privilege is different in Brooklyn, and those who have access to resources that actually can create better health is probably happening in Brooklyn. But I would have to look to see what else is going on. I'd love to be able to say, yes, it was because I was there and I spent so much time there, and that's the borough I oversaw, but I think there are other factors that are happening in Brooklyn. I mean, I will say, what I did see change in Brooklyn, the time I was there, was infant mortality rate in Brownsville. where it was, typically the lowest across the city for many years, and it still is one of the lowest, but it's not the lowest. And I really think that that is in part because of a large effort of many different people now starting to have focus on home visiting programs and anything that helps support decreasing infant mortality within Brownsville, and those groups coming together to help think about, common agenda and common goals. But as far as the borough as a whole, I think there's a lot of changing demographics in Brooklyn.
So there's one other thing I wanted to talk to in terms of maternal and child health. We are doing we have a small planning grant that we got from the Cornell for a planning grant to do doula services. And Brooklyn, had been doing doula services for a long time. But no one has actually ever done any research in terms of the knowledge, attitudes, and utilization of doula services. So the Bronx is hopefully, if we get the grant to do the research, we will be doing that. But just in some of the anecdotal discussions I've been having, some of the clinicians, many of them are not really that receptive to doula services, and one of the obstetricians said to me just last week that they're bothersome. They're just bothersome in the birthing room. And I'm really concerned about if I want to get doula services going on in the Bronx and the clinicians are not receptive to it. How did Brooklyn get off the map? Because you've had your doula services program there for a little while, and I know that because you were one of the people that helped do it.
Yeah, I think again, it's a conversation that probably just started before it started in Bronx, and you started initially it wasn't that easy, and I think over time the relationships have developed, the culture has changed again. And the demand is different. And once the demand starts to be there, that starts to shift culture on the clinical side slowly. But it definitely starts to shift. So what I do think, because we were actually having this conversation a little bit earlier today, is that we as a city, and so I'm actually happy to hear that you're doing research in the way that you're doing or applying for the grant. Probably we need to come together, and we're probably going to work on convening the folks that are doing doula work across the city to start being more strategic on how do we support the capacity to have doulas. Also, how do we engage those who can be vocal and put funding towards doulas on the city level? And then how do we get more resources as well as far as to how do we evaluate doula programs across the city so that we can show more evidence that these are effective programs. But also it's sharing this information that's out there too. We know for doulas that recently ACOG actually said that, and they fully support having doula support at deliveries. This is a national clinical organization for obstetricians, and they are saying doulas are good. And so we need to get that information and conversation out there more. So that has to be more through some of our networks that we have with physicians and doing more training and support around there as well.
And my last point, then I'm gonna sit down, is that we had a stakeholder meeting beginning of March, and we found that many of the clinicians, and we had a diverse group of clinicians, not just obstetricians, and stuff, but others as well, don't even know what doulas are.
I'm sure that,
And then we had some women, pregnant women, who never heard of doulas either. So a large part of it is going to have to be educating both the clinicians and the community, pregnant women or women in reproductive age, the preconception, interconception group, about doula services and why it's a good thing to have, but also just in terms of bring back the idea of breastfeeding. There are so many women that just are so against breastfeeding, and Black women specifically I'm talking about. So we're trying.
Absolutely, we appreciate that. I think that's a large goal is us understanding as an agency, even though, especially breastfeeding, we definitely are, most public health people are at the forefront of pushing and really ensuring that all babies have the opportunity to have access to first foods or breast milk. Not everybody's on that same page. And so there are different ways in which we're trying to help support that conversation and for it to be out there. But again, that has to be through partnerships and many times engaging people who you wouldn't think would be engaged. So as an example, I know Borough President Adams Councilman Robert Carnegie and Walter Mosley, who's an assemblyman, all of them have created baby and breastfeeding friendly spaces in their offices, right? And so, and now Borough President Adams is now this coming week having a rally to support paid leave and expanding. We have a breastfeeding empowerment zone and other supports for mothers and families. So those are the kind of folks that we have to start getting engaged in the conversation, because once they start to use their platform and voice, especially as African American men at that, people listen.
Thank you.
Mm-hmm.
Oh, I forgot my question. Thank you for your comprehensive review. I noted that you mentioned that you had engaged, you had initiated anti-racist training for the staff in the health department. And I wondered, how effective has that been? Is there some way in which you could measure that? And also, have you considered implementing that in the police department as well? And what outcomes would you expect?
For the first question, so I started in this position in September. So just to say, we are very new. We are a new center. So we are in the process of planning to have anti-racist trainings. Right now, the way we're supporting capacity is more so having, the commissioners having brown bag lectures from some of the top theorists and people who've done this work on anti-racism and developing anti-racist organizations as well as anti-oppressive organizations coming to the health department. So we are now in the process of sitting internally to talk with the champions. So there's a process, we're learning that the process that it takes to go through. And usually the first step is, even before an assessment, is identifying who are your champions within the health department. Who are people who are, one, value the conversation, who understand the conversation, and that you are able to bring to the table that can kind of work towards supporting what are the plans that we should put in place and the process in order to get to an anti-racist organization. So we're identifying those champions, and we want to have an inclusive process. So we're actually creating somewhat like of job descriptions that will go out for people who are interested, and they can apply in a sense and say they would love to be a part of the leadership team. And then once the leadership team convenes, then one of the next steps will probably be an assessment to understand where we're at as an organization. Because before you can bring in training, we have to understand what people are thinking. We can make a lot of assumptions about where they are, but we don't want to do that. So that's the first step of what we're doing as far as training goes. And then we'll have to figure out our ways to evaluate the process as well. And then as far as NYPD, it's not my agency. So that's not for me to particularly comment in that way, but we are working on different levels with many different divisions departments, and NYPD being one of them, to have more conversations about how we all are engaging on the neighborhood level. So those doors are open, I think more so than they ever have been before in the past, for us to work across city agencies to start having more fruitful conversations so that we can get to better solutions to help ease some of the tension that we know exists in our neighborhoods.
Hi, how are you? Sorry. My name is Ala Axelrod, and I just recently graduated Hunter College, and I'm hoping to go on to pursue a medical degree in MPH. So I'm just wondering if you have any advice for like the next generation of healthcare professionals or public health professionals about how to get involved in the conversation or in the community health, if you have anything.
Sure. Usually, what I tell med students is, one, and there's lots of public health students and there are lots of med students that are interested. At this point in time, I think your generation has an opportunity that my generation definitely was disconnected from. I always say I was raised in a generation that grew up and got good grades and was told to go to school. It's okay. Civil rights was fought, and I'm talking about specifically for African Americans and people of color. But civil rights was fought, so you guys don't have to worry about, if somebody calls you the N-word or whatever, don't worry about it because you can still go to school, right? And you're still going to get the degrees that you need to get. But what happened was, in that process, is that now my generation and a little below as well, we're disconnected from the idea of what it means to be collective and the importance of being collective and really change. And the baby boomers get it, but my generation doesn't get it. And so I think there are opportunities for your generation to really become involved and understand in a very passionate way and connected way of what inequity feels like and what inequity looks like. It's very visible right now. It's very visible, more visible than it's ever been. It's not that it hasn't always been there, but it's there. So I say to become active in what's important to you on whatever level it is, but start to understand what leads movements, what community organizing is about, how change really happens. Because at the end of the day, as a professional in health or public health, our role is to try to change behavior, right? Behavior understanding it's influenced by many things. So if you have a broader context of how to do that on a community level, I think it's tremendously powerful, as just far as the context of understanding public health and health. I also think the experience and knowledge is valuable for moving into public health now as well. I know from my perspective, I'm hiring people who have more community organizing backgrounds, even if you're an urban planner or a researcher or somebody who has that kind of experience and that just broader knowledge of the importance of collective and how do you really move people. And other health departments that are on the front line as well. We're shifting away from, pure community education and educators, and not that they're not important, but that's an important piece of doing some of this broader work. Even if you want to go into policy and law, organizing and having that context to that still becomes very important. So I say to do, what your passions are, understand the importance of being collective, whether you're working with your fellow students or other people or working with other organizations, and diversifying your portfolio in that way.
Thank you very much.
You're welcome.
Hi, thank you so much, Dr. Maybanks, for accepting our invitation.
You're
and
welcome.
on the heels of that comment, what would your charge be to academic medical centers? I think New York State probably has maybe 8 to 10 medical schools now. So what's our role? Because I know, and not the schools of public health, because there's an inherent social mission to schools like Hunter, but academic medical centers, and Dr. Reed on the panel before was talking about how when you look at research, there's a hierarchy to research. It's the basic science, and then here is what we do, the community-based research. So what advice would you give to academic medical centers to address health inequities?
Sure, I would, and this is not a plug for my commissioner, but it is. I would recommend reading her article. I think it's a great start because that's exactly what she talks to, about the role and the importance, or the role that academic health centers or clinicians have to play in solving health equities. And it really starts with, again, highlighting and looking at our own selves and our own institutions. So academic centers have a responsibility on how do they train students, and do they train, or not only train students, but train their staff, and how are they looking introspectively to really change over their systems and policies and practices on how they look at the neighborhoods that they're serving, or how are they looking at people that they're serving. And once you start to do that level of training, it's not easy, and I get it. And sometimes that means you need to bring on outside help in order to help achieve it. We're doing that. I mean, it's a lot of work. But it's once you do that training, then how are, even simple assumptions in language and how, clinics are set up, and I try not to use that word, but I use that because that's what people connect to. The language around that and the two-tiered feeling of the system. There are many changes that can happen. How do you connect with the public health system? How do you not say, that's the social worker is supposed to do that? All of those are, I think, that's changing culture and practice, and that can only come from leadership. Or it has to start with leadership, let's put it that way. Because I recognize that if the leadership does not say it, it's really hard to help transcend through an entire institution. But what you can do, and because it's academia, and I feel students, have this ability that if they get agitated, they will agitate.